Okay, awesome. So we're gonna go ahead and get started. I did start the recording. I am just going to have to, it might take me a little bit to upload the recording just because you guys don't have like a Teams page for your Patho class. So I'll have to directly upload it into Canvas. But not to worry, it will be recorded and it will be sent to you guys one way or another. If not, I can always send it to Dr. Rinaldi and she can upload it under like the modules and stuff for you guys as well. So before I begin, a little bit about me. This is going to be my third time tutoring pathophysiology this semester. It's my first time working with the St. Pete cohort, so I'm very, very excited. In addition to pathophysiology, I also tutor pharmacology and complex health 1. So this semester, I have 2 sections of patho, 1 section of pharmacology, and 1 section of complex health 1, which are all courses that you guys are going to be going through. So if at any point you need anything, you have my email. I'm very, very receptive to my email. Please just let me know how I can help you guys, because I really love teaching, I love instructing, and I like just being a mentor for all of you guys. So again, here is the link to my NAC session. Again, it's just going to be the best way for you guys to stay updated with me. And if we ever need anything, that's how we're going to go about scheduling. For scheduling, shoot me an email and we'll work something out. I am in the process of setting up some virtual office hours for you guys where you can just drop in and come see me. So if you guys haven't already filled out the link you were sent by Dr. Rinaldi, go ahead and do that so I can best be available for you guys. So let's begin. So let's start out with what do I need to know? I know it got cut off a little bit, no worries. But basically we need to know, what is this? What am I even talking about? But again, no one's going to ask you to give the textbook definition of disease processes. Something I like to explain is if your patient, an elderly woman, just got diagnosed with type 2 diabetes and her daughter comes up to you and says, what is this? My mom's never had a problem with her liver. It would be up to you to educate her. Well, actually, type 2 diabetes, it's acquired, but it actually is involved in the pancreas, not the liver. But basically enough to provide that education to your patient in simple, digestible terms that they're going to understand. That's the extent of what you guys need to know. Up next, you really want to know, what would a nurse look out for? What are my nursing considerations? If this was a patient I was treating on my med-surg floor, how would I care for them? What would I do? Or more importantly, what would I not do for this patient? And then finally, those hallmark signs and symptoms. So many disease process cause GI disturbances, all those things. These are really hallmark signs and symptoms that are tailored to your patient. You're going to learn about treatments and further nursing considerations, symptom management when you progress through the nursing program, when you get into pharmacology, complex health 1 and 2. This is just your basic patho. For example, I'm in complex health 2, and we're going over SIADH, DI, but we're learning how to treat the exacerbations or the worst of the worst case scenarios. So that's why this is really awesome and good foundation for you guys. Up next, I just have a little bit of tips for success. If you guys, I really recommend for this course and your PCC course, any sort of like practice questions, really to get you used to taking those ATI and NCLEX style questions. You can create your own study quizzes, which I listed here on the PowerPoint, how to do so. We all pay for ATI, might as well make the most of it. In your textbook, there's great end of chapter questions, case studies. I really like Osmosis by Elsevier. I wouldn't recommend paying for a membership or anything. Most of it you can find on YouTube or some other websites. And again, at the bottom is kind of like, what do I need to know as a nurse moving forward? So basically how this is going to go, Dr. Rinaldi sent out the blueprint. This PowerPoint is the blueprint. We're just going to rock and roll and go through it. So up first, we're going to talk about genetics. So here are your 3 types of genetic terminology that we want to talk about. So our karyotype, that's a complete set of chromosomes. Really, this puts them in order from 1 to 23. And it's a way that for DNA analysis, we can kind of look at a patient's genetics. They should have 23 chromosomes from mom and 23 from dad, and they form together a pair of sister chromatid, and that is what our genes are. I have anything in italicized is kind of like put it in the chat, or if you're brave, shout it out. But if we had a karyotype on someone who had Down syndrome, what would that show on the karyotype? Do you guys know? A little hint is
321.
Yes, awesome. There would be on chromosome 21, it would show 40, it would be like, so the total would be 47 chromosomes, and on chromosome 21, you would have 3. So very, very awesome. Up next, we have our phenotype. Think phenotype physical, what we physically see. Does anyone know some examples of phenotype? More specifically, what would a phenotype for Turner syndrome show? So Turner syndrome, that's when a female, instead of having 2 X chromosomes, she only has 1 X chromosome. So that would be like her genotype. But physically, what would we see in someone that only has, in a female that only has 1 sex chromosome? We would physically see some anomalies. Especially with Turner syndrome, you're going to have a short stature, webbing of the neck, etc. And then up next is genotype. So it's the genetic makeup that contributes to the phenotype. There's homozygous and heterozygous. So homozygous, think of Mendel's peas. Heterozygous, that's when someone has a little bit more mixed genes. But yeah, a lot of that was your microbiology from quite a few semesters ago, but just a nice little refresher. Up next, we're going to have our chromosome aberrations. We have polyploidy and aneuploidy. So polyploidy is when an individual has more than 1 complete set of chromosomes. So they have 2 extra that are together, forming that sister chromatid. Therefore, it's a homologous set. Now, this is not compatible with life. So usually, unfortunately, it's often diagnosed in pregnancies. But any type of polyploidy, it's not going to be compatible with life. Aneuploidy, on the other hand, it's when they just have an abnormal number of chromosomes. For example, our trisomy 21, that's our Down syndrome. Down syndrome is compatible with life. Same thing with our trisomy 18, which is our Edwards syndrome. So this just means they have like an odd number. They have 1 extra or 1 missing. They're going to be monosomy. That's if they were missing 1. And then trisomy is if they added 1. And major takeaway for this one, it is compatible with life. So when we're talking about our single gene disorders, really think of Mendel's peas when he was growing his flower plants, all of that. So we have our autosomal dominant genes. So an autosomal dominant gene is very, very common because in order for a child to inherit this from their parent, they really just need 1 gene, and that's the gene that really takes over. That's the one that's going to be expressed. That's the one that's going to be shown. Now, our autosomal recessive disorders, these ones are a little bit rare because in order for a patient or a child to show this and not just be a carrier, they would need to have both of those little tiny R's. Autosomal dominant, that's your capital R, whereas your recessive, that's your lowercase r and your lowercase r. So just keep in mind knowing really which one's more common, which one's not. And then also some genetic disorders are carried on the sex chromosome, which is why biological males are a lot more susceptible to certain genes that are carried on that X chromosome because they only have one X. So that's the one that's going to show forth. So that's just a little genetic review. Up next, we're going to talk about altered tissue and cell biology. So I would be, for exam purposes, I would just know really the top two ones. Sometimes the top three are just really important. But think about pathophysiology. As a nurse, what would I be seeing this? So when my patient has tissue atrophy or cellular atrophy, those cells are shrinking, they're wasting away. Something I like to always say is a patient gets put in a cast. They can't move that limb. They haven't been moving that limb. What happens when they take the cast off? It's skinnier. There was a muscle loss. That's going to be our atrophy. Some physiological reasons are thymus gland. As we get older, the thymus gland actually atrophies after puberty. Up next is hypertrophy. That's just going to be your increase in cell size. And really some patho reasons that this would happen when we start getting into our cardiac lectures. When there's any sort of heart valve dysfunction or anything that requires the body to work more, you're going to have tissue hypertrophy. In the same way that bodybuilders, when they use those muscles more and they add in a lot more stress, the muscle hypertrophies. Hyperplasia is just going to be increase in the actual number of cells. Metaplasia, that's replacing one mature cell type with another. And then our dysplasia is non-reversible, and it's actually a change in the phenotype of the cell. But again, really your top three are important. We have up next is cellular injury and apoptosis. So most cell injuries, if they cannot be healed by the body goes into a process called apoptosis, which really just helps regulate making sure our cells are in check. If there's any sort of damage or irregularities, our body's going to trigger apoptosis. I'm going to talk about that a little bit more on the next slide. But the most common cause of our cellular injury is our hypoxic injury, meaning the cells aren't getting enough oxygen and therefore they die. If the cell doesn't receive oxygen, it's not going to be able to pump ATP. The cell's going to really just go into overdrive. It's going to swell. The outer membrane's going to be damaged. The contents can leak out and whatnot. Our ischemia reperfusion injury, that is an injury caused by the restoration of blood flow and oxygen. Think if something hasn't been receiving oxygen for a while and all of a sudden we pump it with oxygen, the body kind of gets freaked out because oxygen is a chemical. And when we've gone, whether it only be a few minutes, if we've gone a little bit without it and then all of a sudden we have a ton of it, too much of a good thing isn't always a good thing. So for cellular injury, there's two different types. There's necrosis versus apoptosis. So necrosis is irreversible cellular injury. Basically, damage occurs and the damage leads to swelling. When we swell a lot, the plasma membrane of the cell just loses its integrity and the cell pieces leak out. This is caused by damage, where apoptosis is programmed cell death. Now, injury to the cell and damage can trigger apoptosis, but when we're talking about apoptosis in this sense, it's the specific process of how this happens. And I included like a little photo for you guys for your purposes, just to review this. And if you guys would like, I can definitely upload you a PDF copy of this as well to your Canvas course, so that way you have all of this in a PDF so you can see the pictures, because I love my pictures. But basically, the cell shrinks in size. There's different chemical mediators that sound the alarm. Something's wrong with this cell. It needs to go. So it causes the cell to shrink, membrane blebs form, they go their separate ways into the body, and then phagocytes end up digesting all of those. Awesome, good, I love that you love pictures. Awesome. So those are just the main concepts of cellular injury, and really knowing that cancer, I don't know if you guys have had your cancer lecture yet. Last time I taught it, it was the first thing that was discussed. Now it's at the end. But just really know that with cancer, there's an issue with apoptosis. Okay, perfect. So with cancer, there's that issue with apoptosis. Apoptosis is not occurring. Cancerous cell bypasses all those checkpoints. If the cell has checkpoints throughout it, and if at any point in any of the checkpoints the cell knows something's wrong, it triggers apoptosis because a bad cell is not good. But with cancer, it just bypasses all these checkpoints. So the bad cell just keeps bypassing all of it, which leads to uncontrolled cellular division. So apoptosis doesn't occur with cancer, at least in the cancer cells, I should say. Up next, we have our fluid and electrolyte imbalances and acids and bases. This is really important, and it's probably one of the most difficult things that you guys do learn throughout cardiac. So I promise once we get through this, everything else is going to be a breeze. So let's talk about body fluids. Really, major takeaway is our pediatrics have a lot more fluid in their bodies than adults do. Specifically extracellular fluid, we have a lot more. So with peds, we're really, really concerned for dehydration. Why? Because their bodies are used to having all of that water. So even just losing a little bit is not good. Whereas kind of adults, I don't know if anyone has currently living like their grandparents or anything, but they really just don't drink a lot of water. It's good to drink water, but they just don't. Whereas kids, they require a lot more water. And then as we age, we lose water in the extracellular fluid and it moves to the intracellular fluid. Up next is edema. I just included this picture for edema, just because it's pretty basic, but I would just know that when we do our nursing assessments, we want to assess for edema. Usually there's going to be pitting edema in the lower extremities. That's just going to be where there's a lot of swelling, and if you actually can like imprint your thumb, it'll leave an imprint. Another thing for edema is it can cause fluid to back up into the lungs. So when you're doing your respiratory assessment on them, you might be hearing crackles. They might feel short of breath, like they're drowning in all of that fluid. For the GI system, really, they're going to have swelling, ascites. So it's just someone that's really, really swollen. But what we're concerned with edema is if we have so much water, it's going to dilute the sodium, which is not good. Speaking of sodium, let's talk about some sodium imbalances. So up at the top, I have your College of Nursing lab values. These are really important. Sodium is pretty easy. Just think 135 to 145. Hypo meaning low, hyper meaning above. So when we have hyponatremia, this is caused by either two things. Salt depletion, such as someone's been exercising a lot, out in the sun, losing a lot of electrolytes, or if someone takes in too much water. This is a ratio. So too much water is going to dilute the salt. Similar to how if you have a package of Crystal Light and you pour it in 8 ounces, it's very potent. Whereas if I poured that in like a gallon, it wouldn't be as potent. So just kind of remember those things. If someone's hyponatremic, we're really concerned that they're going to be tachycardic, possibly have seizures. They're going to feel very, very weak. Whereas hypernatremia, that's when someone has a lot of salt. They're going to be holding on to a lot of fluid. Similar to, like, I don't know if you guys have heard, like, salt sucks. Where salt goes, water flows. So if someone's holding on to a lot of sodium, they're going to be holding on to a lot of water. So they're going to have edema. They're going to be presenting with your signs and symptoms of dehydration, which would be that decreased urinary output. They're going to be very thirsty. They're going to have that increased blood pressure, anxious, irritable, because they're going to be big and bloated. Sodium is really important because it functions in both active and passive transport. But there's a really big relationship between fluid and water. So if a patient was brought in with a fluid loss, we're really concerned that they're going to be hypernatremic. One of the most common things you'll see in the clinical setting is, especially with our peds, we're concerned if someone's had a lot of diarrhea, a lot of fever, infection, heat stroke, very sweaty, burn patients. They're at really big risk for things like these. So just know like your lab values and some of the signs and symptoms associated. Up next, we have potassium. I always like to start this out with like a little phrase that kind of helps me. It's just called salty bananas. We wouldn't put salt on a banana because that would be absolutely disgusting. And I say this because potassium and sodium have an inverse relationship, okay? They don't like each other. Where one goes, the other leaves. So if your potassium's high, your sodium's low. If your sodium's high, your potassium's low. So that's just a little thing I like to help because it's really important to understand that now we just covered sodium imbalances. So if I have a sodium imbalance, I'm probably going to have a potassium imbalance as well, and that's not good. Why? Potassium pumps the heart. It's very important. So if there's any imbalance in potassium, we're going to see that on the cardiac monitor. So if you know your patient's dehydrated, if you know if they're hyper or hyponatremic, you're probably going to want to put them on a cardiac monitor as well. Again, with the salty bananas, a good way, I've heard some people say 3.5 to 5, like, usually when I go to the store, I pick between 3.5 and 5 bananas. So that's another way to think about that too. But just really knowing that if someone has hypokalemia, they're really going to have that hyporeflexia, nausea, vomiting, anxiety, coma, etc. Whereas if someone has hyperkalemia, they're going to have those increased deep tendon reflexes. They're going to have a decreased heart rate, blood pressure, just because when the heart gets irritated, it's similar to the brain. They don't like being irritated, so they're just going to go pretty crazy. Some nursing considerations for this is we never give potassium IV push because it's going to burn. We never give it IM. We never give it SQ. How we give it is we have to dilute it in an infusion, in an IV infusion. Some possible causes of a patient not getting enough potassium are NPO patients, our fasting patients, patients that are on certain diets. So if we know that we're prepping my patient for surgery and they're not getting in anything, I'm going to want to do frequent labs just to make sure their potassium is within normal limits. If not, I might need to hang potassium to help bump that up. And then just knowing that certain diuretics can impact your potassium levels as well. Up next is ADH. ADH is our anti-diuretic hormone. Diuretic meaning pee. Anti meaning no. No pee. This causes the patient to hold on to a lot of water. So basically, it's produced in the hypothalamus, but it stays in the pituitary gland. How this hormone works is it stops the patient from being able to urinate, leading to water retention, and triggers vasopressin, which helps increase our blood pressure. So we all know that edema kind of messes with that blood pressure. It's going to be a lot more bounding. It's going to be a lot higher. But basically, by increasing fluid, it's going to increase our blood pressure. So if patients are hypotensive, their body's going to compensate by releasing ADH. Also, there's different chemical receptors that kind of sense the sodium and water imbalances. So I would just kind of know the very basics of what does ADH do? It conserves water to increase our blood pressure. But if someone is holding in a lot of water, they're going to be edematous. So we're a little bit concerned about that. On aldosterone, on the other hand, also is kind of a player in this blood fluid volume imbalance. However, aldosterone comes from the kidneys. So if there's any issues with our blood volume, blood pressure, sodium, potassium, whatnot, it's going to be released. And what this does is it saves sodium and pitches potassium. So if we're going to try to conserve water, we also need to conserve sodium. Why? Salt sucks. Where sodium goes, water flows. So by saving sodium, we're going to save water. But like I said, sodium and potassium are inverse. So if I'm saving my sodium, I'm getting rid of potassium. So these patients will actually excrete potassium in their urine. Think of the RAS system, the renin-angiotensin system. This is kind of the renin-aldosterone-angiotensin system. This helps with that as well. Any questions? I know that was kind of a lot, but if you guys ever have any questions, feel free to just shout them out, put them in the chat, anything like that. Up next, we're going to talk about ABGs. If you guys are struggling with ABGs, come see me. Or there's great websites where you can actually do practice ABGs, where you can kind of quiz yourself. I promise ABGs don't go away. I'm learning about them right now. And it's really important to understand them. The major takeaway, how to interpret ABGs, is you have to know your normals. So I have your normals here. So the first step to determining what someone's ABG is, we need to figure out if it's acidosis or alkalosis. If my pH is less than 7.35, it's going to be acidosis. If it's above 7.45, that means that my ABG is very basic, therefore alkalosis. So when we're thinking of basic, our bicarbonate is basic. So just keep that in mind. Whereas our carbon dioxide, that's acidic. So if someone has a lot of CO2, they're going to be pretty acidotic. Whereas if someone has a lot of bicarbonate, they're going to be pretty basic. So let's talk about acidosis. We have our metabolic versus our bicarb's normal range was 21 to 28. Yes, it gets a little tricky. You'll never have on your exam like something that's 21 or 28. It really just depends on like your instructor in your class. I know for USF Tampa, Dr. Zambrowski teaches 22 to 26, but then Miss Stroop, my professor, teaches 21 to 28. But if your professor says, if Dr. Rinaldi says 21 to 28, then go for that. But you guys also will never have like a question where it's like, oh, their bicarb is 21. Like their bicarb's either going to be like 7 or it's going to be like 34. But yes, awesome. 21 to 28, perfect. So when we're thinking of metabolic anything, there's an issue with bicarb, point blank period. When we're talking about anything respiratory, we're thinking about CO2. So if someone has respiratory acidosis, things such as respiratory depression, sedatives, someone is not breathing as much, they're at risk for respiratory acidosis because they are not blowing off that CO2. Hyperventilation, if someone keeps breathing in and in and in and in and not getting out that CO2, all that acid builds up. So that would indicate respiratory acidosis. Whereas if it's a problem with our metabolism, we're going to see all of that in our bicarb. So yeah. For alkalosis, again, metabolic versus respiratory. If someone's having respiratory alkalosis, I see that it says hyperventilation. I think I made a mistake on that one. I apologize. But respiratory alkalosis occurs when the lungs are losing too much CO2. So yes, if someone would be hyperventilating and they're breathing out a lot, they would have that. Whereas acidosis would probably be someone's just really not breathing in or out very much. So like think respiratory depression, that's going to be our acidosis. But yeah, if someone keeps breathing out and out and out and they're not breathing in, we're going to lose a lot of that acid and kind of put us more towards like basic. But the main takeaway again for this too is if I'm looking at my ABG and I see my bicarb is normal, but my CO2 is doing something weird, I need to see, okay, well, my CO2 is off. Does my CO2 match acidosis or alkalosis as indicated in the pH? And here's again another picture of some signs and symptoms of respiratory alkalosis versus acidosis, metabolic, all that, just for your, if anyone was curious about that stuff. But see, like respiratory acidosis, someone can't catch their breath. They're having an anxiety attack, things like that. A word about compensation. So compensation occurs throwing off those lab values, but don't fear, look back to your pH. The pH is like the king. It's going to trump everything. Therefore, if my CO2 is abnormal, but my CO2 is high, indicating acidosis, but I look at my pH, and my pH is indicating alkalosis, I know that my CO2, my lungs are going to try to compensate. So always look at your pH and find out what matches. What matches with my presentation? Presentation being your pH, and how to work from there. So that'll help you guys with compensation. Up next, we're going to talk about immunity. I included on this just knowing that like our vaccines are going to be our artificial active immunity, and our passive immunity, our passive natural would be maternal antibodies, etc. So just like good little helper tips for you. So inflammation. Inflammation is part of the body's second line of defense. Our first line of defense, those are our physical barriers. But when a pathogen reaches those first physical barriers, we're going to go into inflammation and fever. And with inflammation and fever, this is a generalized, localized response. If it's or fever, when you take someone's temperature, that's going to be systemic. But if someone's having inflammation, they're going to have that localized heat, if that makes sense. But for inflammation, hallmark signs and symptoms, that's your redness, your heat, your swelling, and your pain. The steps for inflammation, basically the damaged tissues release histamine. Histamines are kind of like our watchtowers. They sound the alarm. They see something happened. I don't like it. We need all hands on deck. So they're going to increase that blood flow. Histamine is also going to make those capillaries pretty leaky. When the capillaries become leaky, phagocytes and clotting factors can now go into the wound and go heal. Phagocytes are going to undergo phagocytosis. They're going to engulf all of that and whatnot. Platelets now move out of the capillary, seal the wound, etc. So those are your basic like steps to inflammation and fever. For our antibodies, I always like to use the acronym GAME DAY. GAMED. So for this, I would really know like what's in the colored stuff. Like our IgG, that's going to be our most abundant, and it's also there for infections. But just know that IgM is going to be the first antibody made to fight a new infection. So if I just did a CBC on my patient, and I got their white blood cell count, and I noticed that my patient had a lot of IgM antibodies, I would assume that this infection is pretty new. Whereas if my patient had a high amount of IgG, I would assume that yes, they have infection, but I think it's been here for a little bit. So just kind of understanding that. Our IgA, those are found in like the mucous membranes. IgE, I would understand that that's associated with allergic reactions. So again, if I notice my patient has a high amount of IgE, I'm concerned that something allergic is happening. And then I wouldn't really focus on IgD. It's really the least understood, and we don't have a lot of it. For our blood groups, I would just know kind of how to classify A, B, and O. Really with A, B, and O, AB is the universal receiver. Whereas our O group is or O negative specifically is going to be that universal donor. And just really knowing that if someone has type A blood, they're going to have anti-B antibodies. Same thing if someone has blood type B, they're going to have anti-A antibodies. So just I would review this picture and just be familiar also with our rhesus factor. So our rhesus factor is really concerning when we're talking about pregnant moms. If mom is Rh negative and is having a second baby that's Rh positive, we're concerned that the mom's body and antibodies are going to attack the Rh positive. This is why there's like RhoGAM shots. This is why prenatal care is very important. So I would also know a little bit about our rhesus factor as well, knowing that rhesus factor is also only going to be found on the red blood cells. So for this, how organisms can cause infections. Here's some basic definitions, just so I would review just these terms and really understanding that in order for a pathogen to succeed and do its job, it has to be able to do all of the following. It's got to resist the body's defense mechanisms. Our defense mechanisms are our barriers, our selective pH, things like that. So I would just go and review these terms if you don't already. When we have our bacterial and our viral infections, just really knowing that bacteria are dependent on the body's defense mechanisms, and therefore they need to be able to resist those defense mechanisms. Whereas our viral infections, they actually have to infect the host cell, hijack the machinery in order to replicate. So I would just know that with our viral infections, this is where our antivirals come in, our vaccines come in, symptom management. Whereas if someone has a bacteria infection, we can give them antibiotics to treat that. So both cause disease, both are not great for the body, but just really understanding that viral infections need to hijack the host cell's DNA because it can't replicate on its own. It can't further infect on its own, where bacteria, they can do all of that on their own. The terms antigenic shift and antigenic drift. Think shift. It's like a tiny little shuffle. So maybe influenza A and influenza B. There's still influenza A and influenza B, but maybe I got my influenza A vaccine, but it's not working this year. But it's still influenza A. There's just tiny little shifts that are happening. Sometimes your vaccine will work, sometimes it won't. It really just depends. But these are tiny shuffling shifts. Whereas antigenic drift, this is where like pandemics come into play. Usually two pathogens end up combining and creating an entirely new pathogen, meaning no protection. Regardless if you have vaccines before, if a pathogen experiences antigenic drift, we're really, really concerned. And usually it ends up coming from a non-human species. Again, I have these little photos of vaccines. I think we all know a lot about vaccines with everything, so I don't want to spend too much time on it. Just know that vaccines provide artificial active immunity, and they contain fragments of pathogen DNA to let the body develop its own antibodies to it. And there's multiple different types of vaccinations. For HIV and AIDS, an important concept for this. Not every patient with HIV will progress to AIDS. AIDS is acquired immunodeficiency syndrome. It's caused by when a patient with HIV, their HIV runs rampant. What HIV does is it attacks the body's immune system cells, specifically our CD4 cells. Prevention is going to be number one for HIV. But also with the amount of treatments we have available now, not every HIV patient is going to progress to AIDS, but ideally without any sort of treatment, more specifically, like if your patient hasn't been diagnosed with HIV, it takes about 10 years to progress to AIDS. So just know that when their CD4 cell count gets below 200, their body can no longer fight infection. Therefore, a patient usually doesn't die of AIDS, they'll die of pneumonia or the flu or anything like that because their body has no more immune system. I don't know, have you guys talked in class about some rare opportunistic infections or any cancers anyone wants to share? You can put them in the chat if you want. So yeah, C. diff is definitely an opportunistic infection. So it would be more common with these patients, yes. And then there's like some other rare forms of cancer. Usually like there's cancer on the tongue as well. So just any sort of out of the ordinary. Yes, all these sorts of things that our general population really wouldn't get because we have a working functional immune system. So lots of like bacterial infections, we're really, really scared for those. Awesome job. Up next, we're gonna talk a little bit about cancer, mainly knowing the reason. How does cancer happen? It is the result of uncontrolled proliferations. I talked a little bit earlier about those checkpoints. If at any point the cell doesn't pass the checkpoint, it triggers apoptosis. It won't proliferate. It won't make more. But with cancer, it goes completely rogue. It does its own thing. And this slide's a little bit wordy, but I did want to have it here for you guys. But the hallmarks of cancer, here's a good summary. Again, love my pictures. So what do cancer cells do? They enable replicative immortality. They keep going and keep going and keep going. They introduce angiogenesis, meaning that the tumors now attract their own blood supply. What comes with blood, oxygen, nutrients, all of that. They resist cell death. Apoptosis doesn't happen. They sustain proliferative signaling. They keep going. They keep infecting. They go off. They evade those growth suppressors. So that's why tumors get so large. And finally, they invade and metastasize throughout the body. So I just know that this is kind of really the hallmarks of cancer. Here's some, just for your viewing, some cancer nomenclature. Usually, this will be how cancer gets staged. Tumor, nodes, metastasize. Tumor, and it goes by size, whereas nodes, how many nodes are involved? Are they mobile? Are they fixed? Metastasize, has it metastasized or not? So that's just like good. I find that really interesting. And if any of you guys wants to go into oncology nursing, that would be really cool. Here's some clinical manifestations of cancer. The caution up is really cool. But really, they're going to have sores that don't heal, bleeding, lumps, just odd skin presentations, cough, unexplained weight loss, anemia. Usually for like our cancer moles, there's a good kind of acronym where basically if I were to have a mole and I drew it out like a circle, if it were a perfect circle, I would fold it and it would be even on both sides. If there's any sort of like irregular border or different color, or all of a sudden it's changing size and shape, those are things I want to look out for. And then a word about BRCA1 and BRCA2. These are genes that produce tumor suppressor proteins. If a patient inherits a mutated BRCA1 and BRCA2, they're going to be at an increased risk for breast and ovarian cancer because any mutation in BRCA1 and BRCA2 mean that it's not going to be as effective, and these genes, their literal job is to suppress tumors. And we know that some of the most common cancers that result in a lot of tumors are the breast and the ovarian. Other types of cancer, of course, but we're really concerned for breast and ovarian cancer. Chapters 14 and 18 is all about neuro info. So pain. really main takeaway from this, I would encourage you guys to know the difference between neuropathic, acute, chronic, somatic, visceral, referred. So go back, review some of those definitions. This little picture gives a little bit of help, but I would go back and review that. Really knowing just the basics of the 4 phases. You have your transduction, transmission, perception, modulation, and all this happens very, very quickly. Our acute pain is quick. It might last a few weeks, but that's acute pain. When we start seeing our chronic pain, that's going to be between 3 and 6 months. And chronic pain puts a lot of stress on the body, which has negative effects. Nociception is how we process and thus feel pain. But no matter what, pain is uniquely defined by the patient. We cannot measure pain. The only way we can ask is you ask your patient on a scale of 0 to 10, how much pain are you in? A patient could say that they're at a 10 out of 10, but they might be sitting on their bed texting, which, for me, that probably wouldn't be a 10, but, we can't assume anything. It is uniquely defined by the patient. We all have our own pain threshold, but just know it's an unpleasant experience that really is identified by whoever's experiencing it. The reason we have pain, though, is we have pain receptors everywhere in the body. Yeah. So fever, some benefits of fever. Fever's not bad. When fever is sustained for a long time or it starts getting into the 103, 104, then we're concerned because now our cells can't handle those temperatures and it can actually damage the cellular DNA. But a slight increase in fever is actually really good. This is how the body fights off infection. So I listed a couple different reasons why fever is good. So just again, go through those, but they basically, all the stuff that bacteria and viruses need for nutrients, fever neutralizes that. So it decreases all of those minerals that the bacteria actually need to survive. Again, killing those microorganisms. It breaks down the lysosomes in the bacteria and it enhances our body's phagocytosis. So again, just good recap on, why fever is good. So we have our coup and our contra-coup injury, or coup-contra-coup, however you wish to say it. So our primary, that's going to be our coup. It occurs at the point of impact. So like the picture says, the patient hit their head on a wall. The first injury is the brain hitting the front. But then when the brain rebounds and it hits the back, that's going to be our contra-coup injury. So that's going to be that second impact happening on the opposite side. It's like our rebound. So again, I have a little example, just how the frontal lobe hits the front, rebounds hits the back. When it hits the back, that's going to be that contra-coup. So why are we concerned with coup and contra-coup injuries? What might lead you guys to be a little bit nervous if we know a patient has a coup contra-coup injury? Why are we specifically concerned? Concussion. We're concerned for concussion. What about concussions are concerning to us? Hemorrhage, hematomas, very good. We're getting closer. Potential brain bleeds, yep. It can cause concussion or hematoma. When there's a lot of bleeding on the brain, awesome, increased intracranial pressure and swelling, perfect. Especially with our coup contra coup injuries, we have swelling in the front and swelling in the back. Really concerning. Hemorrhage, all that blood leaking out is going to increase intracranial pressure. The brain is a closed box. Something has to give. Usually cerebrospinal fluid will displace first, but if there's a lot of swelling, the brain has nowhere to go. So it actually ends up squishing ventricles and it squishes basically the brain. And if it extends enough to the brainstem, that unfortunately does lead to death. But especially with increased ICP, the brain has a lot of glands, our pineal gland. There's so many controls. Our respiratory control center is in our brain. So if there's any sort of swelling that's messing with those parts of the brain, we're going to see symptoms everywhere. So our increased intracranial pressure, our autonomic control, our ANS, our control center is in the brain. So if there's any sort of damage to that, our body cannot regulate temperature on its own. We're not going to remember to breathe on our own. We're not going to control our blood pressure on our own. So we're really, really concerned. Basically, the brain does all the stuff we don't actually think about doing. So this is why it's really concerning. So any sort of increase in intracranial content, usually going to be from edema, from swelling. So first you're going to see for signs and symptoms of increased intracranial pressure, the first thing we're going to see is my patient's just level of consciousness is just going to not be what it was. But first they're going to be confused. They might have been answering, hi, name, date of birth, do you know where you are? They might have been answering that at the beginning of the shift, but now they have no clue what year it is. They don't know where they are. I'm going to suspect that there's something wrong with the brain. Headache's going to be one of the usual first symptoms. But then this is eventually going to progress to abnormal blood pressure, abnormal pulse, possibility of seizures, that altered respiration pattern, why that respiratory control center is getting squished. And then finally, like the eyes, the pupils, they're not going to be Perla. On the right, you'll see Cushing's triad. This is caused by increased intracranial pressure. And if a patient has all three, we can pretty much safely say their brain is swelling and we need to act right now. So they're going to have that increase in blood pressure and that drop in pulse. The pulse is tanking, so our body's going to try to compensate with that increase in blood pressure. But unfortunately, it's not going to work because that pulse is still going to keep going downward. And then decreased respirations. My patient's respiratory rate is going to be very low, or it might be just abnormal. They might have agonal breathing. It's just going to be odd. And I'm sorry, but that's just the best way to explain it. Different types of brain injuries. Again, I included some extra stuff just because the brain and the heart are two of like my favorite things. So I just put in a lot of information, but just really knowing like our primary brain injury that happens at the time of injury. Secondary injuries, while it's not super important for you guys, just know this is what happens if we don't treat our brain injury. Our increased intracranial pressure, that's actually going to be a secondary injury. Because the concussion, the primary injury, is what caused it, but then it led to increased ICP. So our contusions, those are like our bruises on the brain. Our hematomas, those are when there's lots of bleeding. Concussions can be staged, different grades. Again, not important for you guys, but just knowing that, they can present with that loss of consciousness, headache, amnesia. There's other type of secondary injuries such as post-concussion syndrome. This happens if the concussion has been undiagnosed and it leads to all these other signs and symptoms. And then our diffuse axonal injury, this is common with like whiplash. When just the head moved at such a crazy force, all those neurons just split. Again, treatment for this one is supportive. So those are just some little interesting tidbits for you guys. Here's some for spinal cord injuries. There's different types of mechanisms for these, and just really knowing, here's some examples of how all of these can happen. But really with our spinal cord injury, we're concerned that there's going to be limited movement below that lesion. So wherever the injury occurred on the spinal cord, anything below, we're going to have a loss of feeling. We're going to have a loss of motor control, a loss of reflexes, all of that below the lesion. Does anyone know something that we as nurses really want to be on the lookout for spinal cord patients, specifically in regards to Foley catheters? You guys talked about that. It's something that happens below the lesion that triggers a crazy hemodynamic response. Have we talked about that yet? This is why it's super important to make sure that with our spinal cord patients, we are frequently checking their Foleys. We are frequently assessing them. We are frequently looking at their blood pressure. We're looking at all of that. So really with our spinal cord patients, we're concerned, again, below that lesion, autonomic hyperreflexia. There it is. Awesome. So what that happens is something below the lesion stimulates the body to just go into a crazy response. And usually they're going to have a lot of flushing above the lesion. They are going to be extremely hypertensive with a widened pulse pressure, meaning their systolic is going to be 180, but then their diastolic is going to be 90. They're going to have a fever, they're going to be sweating, and they're going to be very, very anxious. So just keeping in mind that with any sort of spinal cord injuries, we're concerned for autonomic hyperreflexia. And just know your patient-centered care of how you would care for a patient with a spinal cord injury, just knowing that it takes a multidisciplinary approach. Lou Gehrig's disease, this is a degenerative disease that really targets the voluntary muscles, motor neurons that control those voluntary muscles. And unfortunately, how these patients end up passing is their brain no longer initiates controlled muscle movement. So they're going to have difficulty speaking, moving, eating, and unfortunately breathing. How the disease ends is usually through paralysis of respiratory muscles. The body is no longer able to communicate with the lungs and the muscles that it needs to breathe in and out. But what's really debilitating about this disease is that the patient's cognition never changes. They know exactly what's happening to them. And then again, I included a nice picture of just the nerve, motor neurons, and just a basic outline of ALS. Myasthenia gravis, this is not Graves' disease. It is a disease of its own, but it's an autoimmune disease that basically just causes issues with nerve transmission and impulses because the antibodies attack the acetylcholine receptors. So usually muscles of face, throat, neck, they're going to be affected first. This requires like extensive medication regimen. But if someone is ever experiencing a myasthenic crisis, maybe your patient forgot to take their medication. You're going to have all these signs and symptoms. They're going to have increased heart rate, difficulty breathing, increased blood pressure. So really the treatment would be giving them IV immunoglobulins. But basically they wake up, they feel fine, but at the end of the day, they feel weak because it's taking a lot of energy and effort to do these movements. Because the body's just having a lot of muscle weakness, especially in the skeletal muscle. Alzheimer's disease, there's no cure for Alzheimer's disease, but it's attributed to acetylcholine deficiency. Basically, plaques build up in the brain, the neurons, and then that disrupts brain signaling. Additionally, again, there's that acetylcholine deficiency. Acetylcholine helps send those messages as well. So as these plaques are building up, there's not a lot of room for that acetylcholine to help out. Usually they're going to start with gradual memory loss, and then it eventually progresses to lack of environmental awareness. I don't know if anyone's ever been driving on the interstate and they've seen gray alert. If they ever see like a gray alert, sorry, I don't know what happened. It said someone else took control over my PowerPoint. Not sure what happened. let me get it going. Sorry about that. I promise I'll give you guys the PowerPoint. You don't have to take it. It's okay, no worries. No worries. Fair warning, this is not your PowerPoint. This is one of my other PowerPoints that was up next, but let's browse. I know this isn't the PowerPoint that I need right now. It's just the one that's up next on my slides. We'll just share my screen for now. Luckily, we don't have to go through. We finished with Alzheimer's. Again, they're gray alerts. We're concerned for basically safety. If you ever see those gray alerts while you are driving, that just means that someone's, usually mother, grandma, someone like that is lost and they've been driving. So it'll say gray alert, like Honda Civic, anything like that. So yeah, we're really concerned Alzheimer's for our patient safety. They might be a little bit combative, etc. Can everyone see my screen right now? Awesome. Okay, so let's talk about some endocrine stuff. So I included this nice little picture of our pituitary gland, kind of connecting it back to that increase in intracranial pressure. But just really knowing that our main alterations we're going to focus on in the pituitary gland is going to be our SIADH and DI. Why? The function of the pituitary gland is to produce that ADH we talked about earlier, antidiuretic hormone, no P, water retention. So SIADH is syndrome of inappropriate ADH. So this is from a hypersecretion of ADH. It's usually going to be caused by like a tumor on the pituitary gland, some types of surgery, specifically brain surgery, certain medications. But really, if we have a lot of ADH building up, we're going to have a lot of fluid retention, leading to that water intoxication and hyponatremia. The patient is not going to be able to produce urine. They're going to have gained probably like 5 to 10 pounds seemingly overnight, basically. So this is why daily weighs are very important. We want to look for edema. We want to look at all of that. Again, all that water building up is going to increase the blood pressure. And with our fluid electrolyte balances, with our hyponatremia, we're really, really concerned for seizures as well. So basically, the patient's going to present with fluid overload. They're going to have a lot of edema. They're going to have a very low urinary output. So just things like that you want to look out for. Our opposite is our diabetes insipidus. So this is when we don't have enough ADH. So ADH helps us conserve water. If we have no ADH, our body's just getting rid of water. It's getting rid of water like crazy. So instead of gaining 5 to 10 pounds, they might be losing like between 4 and 20 liters, which is insane. So they're going to have a lot of polyuria, meaning peeing a lot, and polydipsia. They're going to be very, very thirsty. It can be neurogenic or nephrogenic. If it's neurogenic DI, there's a problem with the brain, the pituitary gland. If there's nephrogenic, it's the kidneys. Whenever you see nephro, kidneys. If you work on a nephrology floor, that's going to be like a kidney care floor, a dialysis floor. But if it's nephrogenic, just think that there's something wrong with the kidneys. The kidneys aren't responding to the ADH. The brain's producing it, but the kidneys just don't get it. So usually history of head injury, why that increased intracranial pressure causes swelling, puts a lot of pressure on the pituitary gland. So the treatment is we're going to give vasopressin. Why? ADH triggers the release of vasopressin. Vasopressin helps us hold water, which is, again, like the picture is super, super helpful. Up next, we have our thyroid disorders. I drew this nice little picture for you guys. Basically, the anterior pituitary is in the brain. It releases thyroid hormone, which releases thyroid stimulating hormone, which then acts on the thyroid, which produces T3 and T4. Major takeaway, our thyroid hormones give us energy. They're responsible for metabolism and energy production. So when we have hypothyroidism, there's not enough thyroid hormone being produced by the thyroid gland. Therefore, they're going to have a decreased metabolic rate, cold intolerance, lethargy, etc. Whereas hyperthyroidism, there's going to be antibodies against the TSH receptors, causing an increase in the goiter gland and an increase in synthesis of thyroid hormone. What's actually really interesting for this is the body is going to not be producing a lot of TSH because the body has so much T3 and T4, it doesn't want anymore. So if you were to get lab checks, a patient with hyperthyroidism would have an increase in T3 and T4. Whereas if you had someone with hypothyroidism, they're going to have a decrease in TH and TSH as well. And here's some like signs and symptoms, but just think like hypothyroidism, that's your low and slow. Everything's going slow. Whereas a hyperthyroidism, that person's on a roll. They are going crazy. Everything else is going crazy. They're losing so much weight because their metabolism is just burning and burning so many calories. For our Graves' disease, this is a form of hyperthyroidism that I talked about a little bit earlier. Specifically for this one, though, it's usually more common in women. And this is like the antibodies against the TSH receptors. But mainly, if someone has Graves' disease, some of the hallmark signs and symptoms are this exophthalmos or thyroid eye disease. I don't know if Dr. Rinaldi told you. I know when she taught me this, she talked about Wendy Williams, the talk show host. Wendy Williams does have Graves' disease. And you can see that that's why her eyes, she has thyroid eye disease. So just this slide kind of puts it all a little bit together. This is just like some basic patho of the adrenal gland. For testing purposes, we're going to focus on the adrenal cortex. The cells on the adrenal cortex are stimulated by ACTH that are then going to go produce like glucocorticoids. Glucocorticoids, that's going to be sugar, blood sugar, etc., which is really important when we get into hypocorticolism and hypercorticolism. So let's start with Addison's, hypo. This person has too little cortisol and too little aldosterone. Really for this, we're concerned for an Addisonian crisis. Hypotension leading to vascular collapse and shock. Where Cushing's, this is when someone has too much cortisol. They're going to present with that truncal obesity, moon face, buffalo hump, glucose intolerance. It's most commonly caused by abruptly stopping steroid medication. That's why we always taper medications. Or if someone's taking too much steroids. Whereas Cushing's disease, this wouldn't be caused by that by like any sort of drugs or steroids. Cushing disease, that's just excess secretion of ACTH. What does ACTH do? It stimulates the production of cortisol. Cortisol has many important functions of the body. So yeah, just really reviewing the difference between hyper and hypo. For our diabetes mellitus, again, know your lab values. Some of the chronic complications of unmanaged diabetes, they're at risk for infection. Why? Glucose triggers the stress response. We're concerned for stroke, cardiovascular disease, microvascular disease, that diabetic retinopathy in the feet, diabetic neuropathy in the feet, or that diabetic retinopathy. That's when people eventually lose their vision. So I put some signs and symptoms of diabetes. Usually they're going to be very, very thirsty, weight loss, high blood pressure. Careful with the weight loss, because if someone has type 1 diabetes, they're going to have a lot of weight loss, but type 2 diabetes, they're going to have a weight gain. So just a little interesting tidbits. I also drew this one out for you guys, how the body manages glucose. Basically, the stomach breaks it down into glucose, small intestine takes it to the bloodstream. We have an increase in blood glucose levels. The body senses that we have a lot of blood glucose levels. The pancreas is going to release insulin to lower that blood sugar. What does insulin do? It helps the cells absorb sugar from the blood and store it in fat. Therefore, the blood sugar gets lowered. So yeah, but just mainly insulin helps glucose go into the cells. With our type 1 diabetics, they have no insulin production. So all that blood sugar is just staying in the blood. It's not going into the body. Whereas our type 2 diabetes, they're probably still producing insulin. They're just insensitive to it. So I did compare type 1 and type 2 diabetes for you guys. Just knowing type 1, that's going to be autoimmune destruction. The body no longer secretes any sort of insulin. So we're not going to give them any drugs to stimulate the production of insulin, because they can't do that on their own. We have to directly give them insulin. Main risk factors is just going to be that family history. I put some signs and symptoms. Mainly with type 1 diabetes, we're really concerned with diabetic ketoacidosis. That's when the patient's just blood sugar will not go down. It is a crisis. They're going to be trying to blow off all that blood sugar with those Kussmaul respirations, and it requires immediate action. Whereas the type 2 diabetes, the beta cells are just less sensitive to it, or they secrete less of it. And it's usually going to be caused by that metabolic syndrome, diet high in sugar and fat, obesity, and just it's more lifestyle, as opposed to type 1 really isn't lifestyle at all. It's autoimmune. This is where you're going to see that slow onset of weight gain. And treatment is usually going to be those lifestyle changes, diet and exercise. And then our metformin is going to help with the insulin levels of the body on their own. You can't give a type 1 diabetic metformin because they don't even have any insulin, whereas metformin is going to help stimulate the production of that. So yeah. Awesome. I think that's everything. I'm going to go ahead and go back to my screen. Oh, I'm sorry. I've been talking and you guys haven't been able to see anything. I'm so sorry. I need you guys to speak up. Yeah, I did stop sharing now. Were you able to see the last of my PowerPoint? Okay, because I did just stop sharing my screen because that was the end of the PowerPoint. Okay, awesome. Yeah, sorry for a little bit of the technical difficulties, but I'll go ahead. I'm going to stop recording. And I am going to post the PowerPoint for you guys and some PDF stuff. That way you guys can see it as well. But before I go ahead and log off, does anyone have any quick questions? Do you want me to go over anything? Anything of the sorts?